Well, thank you, Jani. This was the story from Finland, but now we're going to go to another Nordic north up country of talking about Iceland. Now, before I start, I have a bit of a conflict of interest to report because I've been for over 20 years occasionally teaching rural emergency medicine courses, so I have had income from teaching airway, but I don't think that has heavily influenced this in any significant manner. Now, what I want to talk about here is not just the manual skill of shoving a tube down somebody's throat, but do it on a bit of a broader perspective. And the first thing is, patient is short of breath, breathing difficulties. And we know from the Hillerød Hospital in Denmark, they did a good study on presenting complaints to the ED and how likely it is that the patient will not survive the hospital admission. And it turns out that dyspnea is at the top of the list. But another thing that we've also always been trained about thinking as a high-risk presentation is chest pain. And can you find chest pain on the list? Nope, it's not there. I had to manually add it. So even if you have a STEMI, the mortality is about 7% during the hospital admission. So it's lower than the shortness of breath patient that's coming to you. Now, we then think about how we deal with these patients in the ED. And here's a defibrillator. I know everybody here in this room knows how to use this and feel fully competent to know when to defibrillate and how to do it. But for the most pressing presentation, there's a myth saying that these fancy gadgets you see on the top picture is something that only anesthesia can use. And there's something wrong with this approach, in my opinion. So the question is, patients having real breathing difficulties, you think they might not make it, you need to take over the airway or the ventilation. And who are you going to call? Who's going to deal with this? And we've had, for quite a while, a bit of a struggle between these two professions in the Nordic area, where there's a fight ongoing, which is, I'm happy to hear from Finland that they're also moving beyond this stupid, childish fight. But we do live in an unusual time of the human history where we are all stuck in echo chambers. It's not just social media, it's not just the politics, but I think it's also in healthcare and in science. And a good example of these echo chambers is when a group of emergency physicians wrote an editorial for the European Journal of Emergency Medicine saying that emergency medicine is great. And then we had the opposite opinion from the anesthesiologists who wrote a paper for the European Journal of Anesthesiology saying that emergency medicine sucks. This is not productive. This doesn't get us anywhere. They should have written this for the opposite position, and it's a good rule of thumb to really read something that you intuitively disagree with, where you think that you don't agree with it, then you should try to listen to them and see if they can change your mind. Now, emergency medicine is not a new thing anymore. We've been doing this for 50, 60 years in the world now, and essentially all of the world has adopted this. And this is old news. To me, I'm more interested in this map here, which highlights in blue all the countries that adopted emergency medicine, but then said, nah, it's not a good idea. Let's go back to the old system. Because in my knowledge, that has never ever happened to any country, to any hospital in the world. Everyone that starts doing this figures out, yeah, of course, this is the way to do it. We're never going to back out of this. And every curriculum that's been written in human history, to my knowledge, had always stated that to be an emergency physician, you need to know how to deal with airways. Goes without saying. Airway problems are acute. You don't have a lot of time to wait. You have to be able to deal with them acutely and do whatever the patient needs to help them breathe. But then this happened in Norway. So Norwegian anesthesiologists are politically very, very strong within their healthcare system. They believe that their system is the best in the world, which is a common thing in a lot of countries. But the good people that I know in the Norwegian Society of Emergency Medicine, they came up with this very nice compromise, saying that, well, if there is no anesthesia available, yeah, maybe the ED doc should be able to do the intubation and save the patient. But guess what? Nope. That did not go through. So when Helsedirektoratet published these clinical curriculum, they said basically the emergency doctor should know when to call anesthesia, call the big guys. And this was an historically stupid thing that I don't think has ever happened before. I know that Denmark also had the same kind of compromise. And I know that this is not something that was what the leaders of emergency medicine in those countries wanted to do, but the political landscape was such that they just, this is what they had. This is the only options they could do. And it's really an interesting thought, because if you compare airway management to echoes, anesthesiologists are doing a lot of echoes by now. They're doing TEEs intraoperatively. But the cardiologists have been giving them a pushback and saying, no, well, you're not allowed to do this. We have to give you the permission to do it. And what do the anesthesiologists say then? They say, well, we're an independent specialty. We get to decide what we dare to do. This is our job. But for some reason, we've not really gotten to exactly the same point with the airways in emergency medicine. And it's an interesting thing. Now, I'm getting old enough that I can say I've been practicing medicine since the last century. It sounds kind of impressive by now. But the longer I work in this field, the more interested I am in like the sociology, the psychology of what we do. And it's an interesting thing that many of us have somehow grown up with the misconception that there is a hierarchy of medical specialties. And sometimes the cardiothoracic surgeon and the neurosurgeons are on the top, and then sort of there's a perceived hierarchy of some specialties being noble, more important, and they can shit down on the other ones and make decisions and tell the other ones what they can do. And if we take a step back and just think about it a bit, this is really, really toxic. This is really wrong. There is no rank order among specialties. We are all specialists in what we do, and each specialty should decide on its own terms how they adopt any kind of technology, be that emergency medicine, be that cardiology or whatever, and be that ultrasound, airway management, or whatever it is that we're doing. No specialty should ask permission from another one to do this. And in my job where I do a lot of teaching also for rural doctors, I always have to remind myself of this, that it's not my job to tell them how to do this. I don't work in the rural environment routinely. I can give them the tools, I can give them the guidance on what I believe is doable, but they have to decide as a community what they can do for themselves. Now, in our part of the world, we have this unique, weird anomaly where people think that critical care and anesthesia are the same specialty. This is just considered a joke in a lot of parts of the world. These are very, very different specialties. Critical care is about some diagnostic, but managing patients long-term. Anesthesiologists are just proceduralists that are trained to do certain interventions. And I have literally spoken to anesthesiologists who believe that the Venn diagram looks like this, who have actually said out loud, there's nothing that an emergency physician can do that an anesthesiologist cannot do. And this, I mean, I know you're laughing, but there are those in that community that really believe this. They think that they are so smart. Now, this is, of course, just complete nonsense. This is not how things really look. I think the Venn diagram looks something like this. We have much more in common with critical care than we do with anesthesia. And I am actively trying to break up this union. I never call anesthesia to come down to the ED. I call critical care if we need their help, because it's critical care that we need. And this specialty is, however, gliding apart. If you look at the big centers here, most of them are either working only in the ICU or only doing anesthesia. And I think it's inevitable. It was a good idea for the community hospital in the Nordic country 30 years ago, but now both anesthesia and critical care has become so specialized that you cannot do both. And doing all three of these is just nonsense. There's no way you can do that. But we're left with this race. People are competing. Who gets to come down first to do the intubation, shove down the tube? And in Landspitalet, we've had this fighting going on for quite a while, where people are basically fighting about who gets to do the intubation. And there's a lot of backstabbing, and like Joni was mentioning, there's a lot of like venting in your break room about how the other department mismanaged things, but we don't really communicate. And a lot of the things that have been said and are floating around here are the myths of emergency medicine, where anesthesia is saying, well, you can never get sufficient training to do this. You can never maintain that level of training by working in the ED. And anesthesiologists are better than emergency physicians at acute airway management. They say this out loud and they believe it. And in their defense, they just don't know better. But these are just myths. There's no scientific data to back this up. And if we just look at the numbers, that the training required to intubate is generally considered to be about 50 intubations. And this is from anesthesia literature, saying that with that you're going to get adequate skills and safety in doing an intubation. But this is with direct laryngoscopy. Now, video laryngoscopy we know now is a way better way to do this, but we don't have a good data on the learning curve, but it's probably somewhere around 15. But that being said, I mean, we know that if you're taught poorly, you can go in and do a procedure 1,000 times and you're still not good at it. Whereas if you get taught really well, the learning curve is probably much shorter. So it's more about the training than it is about the actual interventions. Now, can you maintain the airway skills by working only in the ED? Here I have to resort to numbers from the US, where we look at major studies where they have here over 50,000 intubations. And it turns out that the average ER doc in the US is intubating about once a month. That's the numbers that they're using. And this is what gives them adequate safety of doing this procedure. So when we then look at where we've transitioned from having anesthesia doing this to us doing this, emergency medicine, it's important that we do this with tracking the results. And there has been done several times in the US before. And as you can see here, with the initial phase of 34 months of anesthesia and then transitioning over to 12 months of EM doing the trauma intubations, there is no difference. The first attempt rate, the surgical airway, the total attempt or success rate is not statistically different in any categories. Trends in some directions of something being worse or something better. And the rate of intubation failure is slim, but what's important in this system, they did transition over. So even if one team was supposed to do it, if they failed, another team can take over. So this is important. When we're doing this, we should be able to cooperate, not fight about this. Now here's another study where they looked at 240 patients intubated by anesthesiology compared to 250 trauma patients by EM. And again, there's no statistical difference. So I urge you, if you're ever confronted with this by anesthesia at your hospital, saying, well, you can't do this, we are better, then ask them for data. We don't care about somebody's opinion. We should make our decisions based on science, based on data. We can't just let it be done on rumors. And just challenge them. Okay, you say you're better. Prove it to us. Show us some research that proves this, because I've been looking for years, but I can't find it. Now, but the Nordic countries are not America. I know that very well. And there are some differences in how we do things. And Jone was telling us about how they keep the patients on ventilators in their department. In the US, we had something called the respiratory therapists. So when I was working in the US, if I intubated, I just walked in the room and said, I want this and this equipment and this medications. And then I said, go, okay, hand me the equipment. And once I've shoved down the tube, I'd say, thank you very much. And the respiratory therapist secured the tube and ventilated the patient. So they do not manage airways, but they manage everything else. When I intubated Landspítali, I'm stuck with the patient. I have to stand there ventilating him, and my nurses are not comfortable managing patients on ventilators. So I always have to have our teams from anesthesia come down and critical care. Now, I was reading, when preparing this lecture, this interesting paper from Daniel Williams and Suzanne Williams about Nordic intubations, where they were looking at the number of intubations in Linköping. And apparently they have only their number of intubations that they do in the ICU from acute patients would only amount to about 2 patients per year, which would be a challenge. But it'd be interesting to see, because there may be some more of them done pre-hospitally. If I understand it correctly, there was only the patients that got admitted to the ICU, but some patients admitted in the ED die down there, they don't make it. So there might be some difference in these numbers. So anyway, at Landspítali, you can see how happy we are now. This fight was ongoing for 30 years. There was no fist fighting, but there was literally shoving with elbows. I'm going to stand at the head of the bed. And they were pushing aside to try to get to the patient. And this was very, very toxic. But basically, we have mostly settled this by now. We call them if we have the time. They come down if they have the time, and if we can, we do this together. We have a combined checklist, we do the procedure together, and it's about half of the intubations that we do or they do. And we don't really care, because it's not really about doing this, shoving down the actual tube. It's more about how you do it, how's the teamwork going, do we have a lot of eyes on the checklist, make sure we don't miss anything, and do it safely. So we're using the knowledge of both specialties in the interest of the patient and not doing something completely alone. Because I am not a critical care specialist. There are things that they know, and now they have started to realize that there are things that I know that they don't. And we can do this together. So an endotracheal intubation is about knowing the equipment, where to find it, how to use it, when you need to select the right medication for each patient, you know when to intubate, and most importantly, you know when not to intubate, when it's not appropriate. And you need to know the team, and you know the safety culture. And the downside to having somebody come down from anesthesia is that they do this completely differently. And an anesthesiologist I know from the US, he calls this ectopic intubations, when you have to do it outside of their comfort zone, because it's a different thing. And I've literally watched an anesthesiologist come down to the ED, give sucks to a patient, and then say, well, is there a laryngoscope here somewhere? Because they don't get, because they're used to do this in the OR. They can do it there, where the nurse anesthetist has prepared everything for them, but you can't do this in the ED. It's a different setting. Now, one thing that we have done also is with the procedural sedation, because we took over these like a decade ago. We've once had to intubate a patient. We've never had any serious adverse events, but we prepare every single deep sedation for a cardioversion or something like we're doing a difficult intubation. So we're going through all of the equipment, prepare the team, do it all like a drill for a difficult intubation, and that gets everybody up to speed. And airway expertise is something that we as emergency physicians should be, and globally, if you say you're an emergency physician, you will be expected to be able to do the airway. It's just an essential skill. So I think globally you would be challenged to call yourself an emergency physician if you cannot save a patient that's not breathing, because it's a true emergency. It's a common and serious thing. Now, we don't have to start this fight again. You're not, those of you that are doing this fight now, you're not on square one. And you can quote things like this from the UK, where they just made a joint position statement by the Royal College of Medicine, Emergency Medicine and Anesthetists, saying the ED should at all times have immediate availability of staff trained and skilled in RSI. Not upstairs being able to come down in 5 minutes, but immediately. If you're in an emergency department, you need to have this skill immediately in the department. So they should use a checklist. They should talk about this in collaboration. And they should have training. So the anesthetist should come down to the ED and get introduction on how we do it, where the equipment is stored and everything. And the ER doc needs to have a chance to go up to the OR to practice and maintain their skills. So I also want to go on a bit of an additional side note of talking about specialization in medicine. Because over the past 50 years, everything has branched out to everybody just want to focus on everything. And if you're an ophthalmologist, you're either a specialist in the right or the left eye or the front or the back of the eye, and you don't want to see the rest of the patient. And this is not just in the US, but also in Europe. A larger and larger number of doctors are only focusing on the tiny aspect of the patient, but the patient is always a complete thing. You cannot break the patient up into organ system, and when you come in, you have a broad presentation. You don't really know what specialty the patient belongs to. Now, what we've also seen is a rise of generalists. So primary care was the first one, and in the Nordic countries, primary care is very strong. It's not as strong as in the US. Now, emergency medicine was the next round, but what's happened in the US now is that emergency medicine was way down, established decades ago. But now the new specialty are the hospitalists. So when you admit the patient to the hospital, you admit them to a specialist in managing sick people in the hospital, who can deal with perioperative medicine or medical problems or a lot of different presentations, but not necessarily just related to one organ. And it's a problem that we are, most of us, trained and live in the bigger cities, and we tend to forget that this is not a map of the Nordic countries. This is, and we should not think about things the way things are done in Germany or some other countries. We have to think about how we can cover our area. And this is a picture of Rigshospitalet in Copenhagen, which is apparently a very excellent tertiary referral center. And I know firsthand that they are very much opposed to emergency medicine. And you have influential leaders, trendsetters in healthcare, which are usually situated at the bigger hospitals. But we, as doctors, we have a duty to maintain the health of all of the people in our countries. So the Vestmannaeyjar, with less than 5,000 people living alone, they don't have any anesthesiologists, but they have emergencies. And how are we going to deal with them? So speaking of Iceland, we do have 2 hospitals with anesthesia critical care available. But the rest of the country is covered by small rural health clinics, staffed by GPs or even trainees or even medical students, believe it or not. So don't get in a car accident in rural Iceland. But I did a survey among those rural GPs a few years ago about airway skills, among other things. And we looked at it that 20% of them considered themselves well trained to do an endotracheal intubation, which I would say is probably an overstatement. But what's more worse is that about only half of them considers themselves well trained to do mask ventilation of a patient. They are the airway docs for their community. They have to deal with this on a regular basis. Now here's a case of an old guy in the countryside in Iceland who took a ground level fall on the golf course, had this retropharyngeal hematoma, came in, and he was fortunate enough that one of our trainees was moonlighting at this rural hospital. He did a CT and saw this, and you think, oh shit. But we trained him well, so he set up everything for an RSI, and when the patient collapsed, he sedated him, paralyzed him, tried to intubate him, but only saw a lot of blood, so he cracked him. And the patient was discharged completely intact a week later from the ENT department. So this is a patient that absolutely would have died unless if he had not had an airway competent doctor managing his case in the rural Iceland. So if we do think about like the populations of how we do things, we have to think about that it's not the same thing to run things in a bigger city, academic hospital, like it is in the countryside, in the rural hospitals. And I was looking here at some information about a number of people behind every specialty physician, and these are US numbers. And if we add this to like 4 physicians of each specialty, because that would be at the bare minimum of having 24/7 coverage of something, we know that for a cardiology service to be at a hospital, you would need at least 60,000 people behind that. Whereas in emergency medicine, you could do this with at least 30,000 inhabitants. So I think that our training in emergency medicine has sometimes been too focused on the bigger academic centers, because that's where you sometimes have the least need for emergency medicine. You can do this with other specialties, but they are very, very important as a training site to be able to go to rural places. So in my opinion, I think we need to restructure this, because many of the mid-sized community hospitals are still staffed by a internist, which may be a rheumatologist, who does not have the right training to deal with this. So I think mid-sized, smaller hospitals should have an emergency department with an observation unit. They should have one hospitalist that can deal with a lot of things and then ship everything else out. And then you add to it as you get to more specialties with a bigger community. So I think that rural emergency medicine is really important, where you can set this up, and I think we should practice and train our people to do this. And in my training program in the US, I wasn't only raised at the big trauma center, I was made to do rotations at 3 different EDs with very different backup. So one had almost no backup, one had medium backup, and then the big trauma center. So that is why we have to ship our trainees out to know what it is to work independently. So we should think our scope of practice not based on the old categories of, hey, I'm specialized in this organ, I should see this, but just only look at, okay, what emergencies are we dealing with in our community? And then what's doable in the ED, what equipment can we use, and can we get the training level to do it? And if we think about it, if we're stuck in a small town, 2 hours away from the nearest big hospital, and we have an emergency that requires these interventions, it's completely realistic that we have a trained doctor that can do all of them. Of course you need to have somebody that can deal with your airway and ventilate you. You shouldn't be choking to death without trying to help you. Acute coronary syndrome. You must be able to rule out acute coronary syndrome and know when to activate cath lab or give thrombolytics. You must be able to do procedural sedation and cardiovert, do a trauma evaluation, chest tube, relocate shoulders and ankles and elbows, hips. You need to be able to do the initial diagnosis of shock and give pressors. You must be able to diagnose acute glaucoma and treat it immediately. Because if you have orbital compartment syndrome, the eye is not going to survive transport to ophtho. You need to do it now. ENT, nosebleeds, peritonsal abscess, urology, suprapubital catheters, testicular distortions, emergency deliveries, neonatal resuscitations. Babies pop out a lot of times here and there. No, often not prepared. We had even last year, one of our junior consultants was seeing this lady with abdominal pain, and then all of a sudden she heard a baby crying in the bathroom. So it happens. And the same thing goes for status epilepticus, stroke, psychosis, and suicide risk. This is a real emergency. It's not just about airways. We also need to manage psychological problems, tox, agitated delirium, and then doing ultrasound. And what we also need is, of course, more online support. And speaking of intubations, there is a term that's been coined, which is telebation, where you do a tele-guided intubation. So you can have a person with minimal training that maybe has done this once 10 years ago, but if you guide them through it, okay, position the patient, gather up the equipment, give this medication now, wait, and then you can guide them through the actual intubation with the video laryngoscope. You can do this remotely and improve the care of those communities. So another thing is that intubation is something that we need to define. When I was doing in medical school, my anesthesia rotation was that I was allowed to intubate 4 times, and then they told me, well, you can't do this, but now you've tried. And they never taught me this well. So with the professor of anesthesia critical care in Iceland and we have come up with a combined course for the medical student where we teach airway management together, but we do not teach intubation. We teach this, basic airway management. And before we start fighting about intubations, we need to make sure that every dermatologist in the country knows this well, because chances are you will end up needing to do this, and you should be able to help a patient that's not breathing. Moving on to the alphabet courses, this is a common thing. Raise your hand if you've done an ACLS course. Everybody does those. Now, there's a difference between the US and Europe about these causes of thought, because in the US, usually the new emergency medicine training does ACLS, ATLS, PALS, difficult airway course, and an ultrasound course in the first month of their training. Because you're not learning how to deal with trauma, you're just learning the basic driver's license, and then you need to practice the whole training program to master the skills. But raise your hand if you've done a difficult airway course of any sort. Okay? Few have done it. And this is a discrepancy that we need to fight. Why is this? Like I showed you on the first slide, the breathing difficulties are what kills us, but we have not done a good enough job to train people for this. So you can attend these difficult airway courses. This is just one that's in the US, but there are a lot of them around, and we need to maybe just import them and do that locally at our hospital. That being said, emergency medicine societies in the US specifically state that if you have a board certification in the US, you should not be required to do those basic courses, because they are not teaching anything that you don't learn much better in your emergency medicine training, so you should not be doing this forever. So to summarize, emergencies related to the respiratory systems are common. This happens every month or every day or every week in all hospitals. And they need immediate care. It's a myth saying that you can wait for 5 minutes for somebody to come down. You need to be able to do this immediately. And all doctors must have basic airway training, and we can and we should, in my opinion, focus a bit more on teaching the basics well. Because oftentimes, if you're in a simulation of a cardiac arrest with a cardiologist, they are focusing on the EKG, and then they say, well, the patient needs an airway. Well, then we intubate, and then we move on looking to the EKG again. Because it's not about it. I mean, airway management is mostly about the other stuff, not just all about the intubation. Emergency physicians and anesthesiologists and critical care doctors and ENT doctors, we're all airway specialists, but we do have different skill set, and we should all work together in teamwork to try to do the best for the patient and use the knowledge we have to save as many lives as possible. So, any questions or discussions or comments? Anybody wants to grab the cube?
Not on. Testing.
On, yes. Just one comment. What I can see, being working in different countries and systems, there is a big aspect in emergency physicians doing all stuff, and that's money. It's crazy what resources we put into, how do you say in English, jourlinje, in doctors working at night, in specialties, and actually doing very little work during their time at the hospital at night, because they're like kind of backup, like a fire service in a country where it only rains and where you never light a fire. And I think that's one of the things, if you develop emergency medicine and you develop your specialty further on, where you need to look at and like show an economic model and saying like, okay, if we emergency physicians are here, actually the anesthesiologists can go home and sleep at home, which they do in the US and in other countries. They go home, or there's one managing the operation theater or sometimes the ICU. So that being in Germany now and for a couple of months now again, and seeing what everybody does, what they feel they can do and they are trained in, there is no discussion about it because everybody has too much to do. So if you do the critical care stuff and, I don't know, putting in A-lines or doing the procedure sedation by yourself, the other specialties just say, thank you, I don't have to come down anymore. And I think that's one of the problems in Sweden, at least. We are just too many doctors, and we waste so much money on that system. Probably an economist or a hospital financial person would welcome the system of emergency physicians doing what actually is in their curriculum. Thank you.
I would like to pick up on what Gerald said, and the study in Linköping, which was referred to earlier on in the lecture, I think there are too many emergency physicians working also at some EDs. We are doing a lot of, maybe not, how should I say it, it's like some tasks could be shifted to other categories or professions, and we could focus more on the critically ill patients. And then we would have larger numbers of procedures per doctor as well. And I think that, of course, one had to... there is no airway registry in Sweden. I don't know if there's any way of tracking airway management in the Swedish. We have a lot of quality registers for pre-hospital and also for the emergency departments, but I don't know if this is something that we actually can find statistics on. And I think that would also be interesting, because I think the numbers are higher than suggested by the article by Wilhelms and Wilhelms, with all respect for their work.
Nice. Okay, so it's mostly a reflection, but I would like to hear what you think of it. My name is Rasmus. I used to be Swedish. I'm trying my best to become Icelandic. I'm working with Hjalti since a couple of years ago. My learning curve in airway management, if we go back to that, has been the one I've always looked up to anesthesia. That's the gold standard. I've tried to learn everything from them, which has been extremely helpful, and they've been very accommodating, teaching me. But as we go along now, as a specialist, with them coming down, I think increasingly for me, the difficulty we have in communication and to cooperate around the patient is because I'm advancing my care now with all the research and all the foam resources that we have in emergency medicine on how to manage emergency airways. That hasn't really transcended into their practice, so we're sort of drifting apart, and I suppose that's also between anesthesiology and critical care. But I noticed this drifting, and 5 years ago, an anaesthetist said to me, I don't know you and your capabilities, I don't trust you to take the airway, I will do it. And now I find myself saying the same thing to them when they come down, because I don't know their practice. And I know what's best for this patient, so I'd rather do it myself. Do you have any reflections?
Yeah, I have a reflection on this with like training with somebody else to learn your specialty, because when you start an EM program, it's completely natural that you say, okay, you're going to be 4 months in medicine, 6 months in surgery, 6 months in anesthesia or something. But we are now changing and shortening those external rotations, because we found out that when we were sending people for anesthesia for 6 months, they were spending 2 months just preparing patients, interviewing them for the OR next day, which is not helpful. So we want to send them not to learn anesthesia, but to learn defined skills that they would use with us. Then we will teach them the EM approach in simulation and then real-life cases on how to do things. And this is, having been in postgraduate medical education for 15 years now, this has been a strong trend where you're not shipping everybody away for long rotations outside of it. And like, for instance, in the Mayo Clinic in the US where I used to work, the EM trainees, they do 1 month of anesthesia before noon. And then afternoon they go do psych consults, because they go to the OR just to learn to do 30 intubations over a month. So they do that in the morning while they're starting the operations, and this is all anesthesia they do, because they do not need more training in anesthesia. Because, like you said, anesthesia, critical care and emergency medicine have a different culture on how to manage airways. So if there's no pressing more questions, I think our time is up. Thank you very much.